So as I say, I work for the Patient Safety Collaborative. We're one of 15 across the UK. Do look us up. We're here to help you with quality improvement and how we do that approach with any projects that you're working on. It doesn't necessarily have to be this one. If you could go on mute, whoever's not on mute, it'd be really helpful. If you find that some of the data feed for this is starting to get a bit wobbly on your screen, it's probably because there's so many cameras on, but by all means leave them on as long as you possibly can. But if you find you're struggling, it usually helps to turn your camera off. If we can go to the next slide, please, Amy. So as I say, I work as part of 15 of us that are leading one of the national programmes around deterioration. And as you can see, it's a very big programme. The bit in red, and we will share these slides and it'll be on the recording for you as well, is around the adoption and spread of deterioration management tools. Some of you will be familiar with, I hope all of you are familiar with News, but there'll be pockets of you that have seen Restore 2 and other soft science tools. So you will have Stop and Watch, Is My Resident Well, which you should all know, Significant 7, which again you should all know, but the one common denominator in all of this is the News score, and that's why it's so important that we encourage people to do that. Sitting alongside this is the Enhanced Care Home Framework, which again for those of you that are working with care homes, you'll see how this starts to align with that and how we strategically start to think about how does that work with end of life planning and advanced care planning, and of course that digital care record, so that everybody can start talking in that one common language. Personalised care and support plans is where that sits into, and how we can start to align this across of our national programmes. Underpinning all of our programmes is what we call a peer framework, and this is where all the programmes fit in together. So we talk about prevention, and that can be in any healthcare programme. How we identify those patients specifically for this programme is around how we recognise signs of physical deterioration. And again, we talk about the News score. Escalation is what we do to respond to it. Do we repeat those observations? Do we talk to other services, i.e. 111, 999 services, or your out of hours or GP teams? And then the response. News is only as good as the people that respond to it. And this is your clinical decision makers. These are the people that need to be looking at those News scores and making decisions based on that, along with your story about your patient through the SBAR process and how you record them. So how does that all fit in to quality improvement for remote monitoring? So quality improvement, sorry, the next slide, please, if you could. So this is around what we're doing here. A lot of it is around knowledge building, how we work together. It's one big team. This isn't working on its own in isolation. So if we put the person in the middle of remote monitoring, it affects primary care, care homes, secondary care and responders, a massive group of people within that group. But how do we pull the learning from that? Some of that is done through forums like this, and you'll have digital forums as well that you'll feed into your programs with. So what's going on in your region that this is working with? We have, as part of quality improvement, the model for improvement, which is your aim statement. Actually, what do you want it to do? How do you want it to work? But keep thinking as well is how we change that. So keep doing little pockets. And this is an agile process that keeps changing as we move along, because we don't want something that's static. We don't want something that's left at the front door and nothing else happens to it. Build the team around it. Use your colleagues. You all know who you're working with, but this is part of the wider multidisciplinary team as well. I'm going to shut up in a minute and hand you over to John and Keith, who, are the Whzan team. They're part of, what is a massive programme now that's going to start running across the UK. And they're here to, as us, tell us what's coming next. But, equally to listen to you, which is why I say do put your questions in the chat, because you will help build some of these systems as well. This is about you as the users, making sure that it's something that you get the best out of and the best experience from. So with that, I'm going to hand you over to John and Keith, who will give you their updates, and then we'll hear from Liam and how he's been using it in his team. Thank you.
Thanks, Tara. Before I sort of start, Paul Underwood has put a note in the chat saying he can't get past the welcome slide. If you've got any technical advice, Keith, you might have for that, can you just let him know, pop it in the chat? I was going to say log out and log back in. Which
Hold on. All right, are you going?
Okay, good luck. Thanks, Tara. Nice to see you again. And also can I welcome Liam. It's his first joining a meeting with us. He's going to speak a little bit later about what he's been doing with his team in NCL. And I've seen his slides. It's very impressive. The whole thing is very impressive. And I think what we can't underestimate is how difficult this task actually is. It's not a simple matter of offering somebody some technology and hoping that a care home will overnight change its way of working and instantly embrace the new technology. It's not easy. And in that kind of vein, really, I'd just like to sort of extend the message that for those of you who want some further support from us, in any shape or form, there's the technical support and the customer support is there from 9 till 5 to answer queries regarding operating of these systems and maybe some fault analysis. But if you want some further support for training for care homes, for community nurse teams for care homes, for helping GPs understand or can appreciate how it can support the work they're doing, just don't hesitate to get in touch with us. There's myself and Keith and the team there. We're doing a lot of that these days as the sort of network becomes more expansive. So just wanted to sort of reinforce the message that it's not a simple matter of saying there's an hour we spent with these people, that's the end of it. No, it's continual, and we're there to provide not only the supporting data about what's happening in your homes, but also there to back you up. So Amy, next slide, please. This is, so some of you will be quite familiar with this. This is the product suite that we developed at Whzan. The first is the most popular really at the moment, being the blue box. Now in, I think, about more than 2,500 care homes with some 70,000 people. Recently, been quite a lot of interest also in domiciliary care, which we began working with some years ago. And again, it's another area where because there are all barriers to how you can support people at home, particularly if they call the GP and can't get an instant call back. So we're working on ways to make that easier. WhzApp is what Keith's going to speak about, which is the free to use multifaceted application, which is growing across certain parts of the NHS who are interested in it, and which is sort of an application we provide at zero cost because we cover the software costs in another part of our activity, which is actually in the Guardian Social Care project. And this is where we provide monitoring for people in their own homes, many of them who are showing early signs of dementia. And the emphasis of this software monitoring is to keep people at their homes for longer. It's being used by local authorities, and in their experience, this is a very, very fast way to save cash. Where local authorities are funding people's residency in a care home, it can easily be £1,000 a week. This is a very low cost system, about 300 quid for the hardware and software for a year. So if they put in £300 of hardware and software, they can get their money back by Wednesday and put it in on Monday. And it's real cash savings, so they're not paying out to put people into care homes. And it extended to what we now call an informal care network. So where traditionally home monitoring such as this, there will be a call center of some description where it should be monitoring for alerts coming from a home where somebody's fallen over. We will share the slides, Shona. This information is available to friends and family, close friends on an app. So the principle being that it's not just the weight of burden or burden responsibility solely on the local authority. Those who are closest to us are much more likely to respond more quickly and be more local than the local authority can be. So it removes the burden from the local authority totally, but also means that the number of people caring for these people who are vulnerable increases. And we've now got conversations running with several other local authorities in the country for extending this. And when we do these programs, like everything we do at Whzan, it kind of starts from a conversation and it moves from there. So it might well be that in this case, with what's called Guardian with the City of Sunderland, has now transpired to something called Sheila, which is an acronym for their app, which is probably a long, long way away from the first conversation we began with them and what they were trying to achieve. And that will happen, be mirrored across other parts of the country. There'll be local requirements, which we will adapt the software for the local requirement and for bringing in local networks too. On the right-hand side of the screen at the top is interoperability, and I'm going to talk about that a little bit more on the next slide, please, Amy. So a lot of inquiries we get from our user base, and particularly at barriers to entry, as to how to make remote monitoring, not just ours, but other people's remote monitoring, easier to deliver. The barriers to entry can be regulatory, MHRA, and we're working on that. We have some MHRA approval already. We're working on what's now called 2A. And along with the ISO accreditations that we have, these things are constantly being expanded and uplifted. So those are one thing we already have in process. Another area which is critical to this, and this is where the primary care community quite rightfully ask for access, is how we can provide data into the patient record. We've worked on this for some months now. We've had considerable assistance from the NHS in the IM1 organisation, and next week we begin testing our data into EMIS. Well, what we've already tested the data into EMIS and tested data into System 1. We're now going through a validation process to answer all the questions we've already answered and check that our answers are correct, that the information can flow in the appropriate manner into these systems. Once this is live, and this should be within several weeks, it then means that what we will need to do with you, when we come back and talk to you, is how we can raise awareness amongst the GP community that they can log on to Whzan with their login and see this information coming from the care home, from their case, and at the click of a button, it goes into the patient care record with the proviso that it says on that data it's been collected inside a care home. And so that's very close to being live. And we know from our experience that once you get GP engagement with the care home, the engagement with the care home just takes off. And then you have the attendant decreases in demand for emergency care and hospital bed days and so on. So that's happening with the EMIS and System 1. We're now also working with the National Records Locator, and again, testings begin with that. So these things began a long time ago, and it's really a matter of us building blocks, if you like, of software to make the language applicable between our systems and theirs, and that's going along again. And that is the National Records Locator will enable information from any part of the system go into a central point, and then you can pull information from it. Most recently with NHSX, we're now exploring with GP Connect. GP Connect is the system across the country. So if you're taken ill in Exeter, say, and have a local doctor look after you, that information can flow to your own GP practice using the GP Connect. That infrastructure we're now exploring, can we use that as a backup or an alternative to EMIS System 1 in case they don't work properly? So that's going on too. So plenty of software development work going on inside the company, both for new product, which we'll come on to in a minute, but also how do we improve communication between you and your primary care community. We went live with Adastra, which was pretty quick. We began that about sort of 4 or 5 months ago. It now means that within care homes who are connected to, in this case, the London and Central West out of hours collaborative, that in their care homes, when they record a new score of 5 or 6, up will pop on the tablet, uplink to Adastra, and they can press on that button. If they do choose to press on that button at that point, the information regarding their client, which is now becoming an NHS patient, being their NHS number, date of birth, clinical history, their news charts, and also end of life advice, can automatically go into the Adastra system. The impact of that is that it will open a case within Adastra before the care home is rung up, saying I've got somebody here in trouble, and it'll have all the relevant data, saving both the call handler at the 111 service 30 minutes and of course the care home. So we are actually, only yesterday we had a call with LCW about how we can extend this into a frail community. So Again, it's another link to another software system, but the purpose being, and the impact, is reducing time, getting faster support to somebody whose health is deteriorating rapidly. So 2 other bits. Now, Whzan tablet software, our 3.0 as we call it, being the 3rd iteration of the rebuild of Whzan, is now in the throes of completion. And we will again be contacting many of you soon to say, would you like to try this? We'll have a look at it in a second. And also the expansion of WhzApp is continuing. And I'm going to throw the ball over to Keith for that in a second. So Amy, can I have my next slide, please? And this is what the new 3.0 looks like. So everything's on one page. The symbol in the middle is the Royal College of Physicians symbol, so because that's where it came from in the first place. And so it's identified with their creation of the news originally about 12 years ago, and now News 2. And just running through the screen, what's on the screen are the instruments inside the blue box, being blood pressure, blood oxygen, pulse, temperature, and then the parts of the news questionnaire. So respiratory rate, which you take by, of course, manually looking at somebody's respiratory rate, and you can touch the buttons plus or minus each time the person breathes in or out. And then there's level of consciousness. And then your reasons why you do it, clinical concern or not, and are they on air or oxygen? And there's the other choices there regarding pulse temperature. They will all be ticked when those things are completed. It's going to reduce the time of taking a News 2 score from probably 3 minutes down to 30 seconds. The instruments will now be instantly uploading this data onto the software, whereas currently you can wait for what feels like an age whilst the instrument uploads the tablet uploads the data onto the tablet. So we'll be rolling this out. We'll be coming to you with sort of saying, how do we do this for you, how you can do it over the sort of coming weeks. So I think that's my bit from me. So Keith and Amy, next slide please for Amy, and I'll pass to Keith. But before I do pass on to Keith, Tara mentioned questions about where we're going to on this, and we will welcome those. You know, difficult that some of them may be for us to deal with immediately, but please do ask us, because your experience on the ground is what really matters. Everything that has been created within Whzan, and there's another on screen right now, has come about through a request from either an individual or a team of people within the NHS. You know, we're only software developers. That's all we do. We do not try and second guess what you want. But so therefore your input to us, what we do, is absolutely critical to make sure that what we can deliver to you is actually what meets fit for purpose. So Keith, it's your show, hypertension screening.
Thank you, John. Thanks for that. Before I start on this, our local hospital are using the new version of the tablet, so they're the first ones to be using it to screen people in queues for hospital appointments. So they're going to meet the people in these queues and do a triage, use the new score, a whole list of other questions, and use that new version to triage patients in the queue. So that's interesting application of the tablet there. So hypertension has come about from areas requesting us to use WhzApp, which is of course free to capture vital signs. And we've got multiple areas now putting WhzApp out into their population to measure blood pressure in a structured program, which is a 7-day, in fact some areas say 5 days, but 7-day program, where the end users are asked to take their blood pressure twice in the morning and twice in the evening. The system then, after 7 days have been captured, will alert the GP practice if that patient's got hypertension. So that's a very sort of typical application of WhzApp. The library of WhzApp functions is really building rapidly. For those, I'll just find a list of those. So we've got now on WhzApp information and tools for COPD, for asthma, for heart failure, for diabetes, for the hypertension, for blood oxygen levels for post-COVID discharge. We've got I Stumble on the app, and we've got Significant 7 on the app, and we're working with a local organisation to put some more stuff on mental health on the app. And if I could have the next slide, please. this is the most recent version of WhzApp, and most recent tools. We work with Sussex NHS, who their continent sections deal with about 100 referrals a month. The way they would work in that is they'd once they get a referral, they'd post out a series of forms to the parents of the young person. The forms would are be used to kind of record a diary of what's happening with that young person, so sort of nighttime events, daytime wetting, bowel and bladder movements, fluid intake, and once the parents have captured up to 30 days of that data, they'd send the forms back. The forms will get digitised by a nurse or an admin person in that department, and then the parents will be called in for a referral to talk about the forms. Once that's done, department post out how did we do survey for parents, and then that would come back in and that would be collected, and they would use that to guide them. So we've changed all of that by turning it all into an app. It's much easier to use. It's going live as we speak, so it's going to go out to the first section. I think it's going to be run for 4 or 5 months live before there's an evaluation by the AHSN. But it allows parents just to instead of having to look at the Bristol stool chart and pick the picture that most represents the poo, they can just do it from their app, and then they get asked the questions about that movement, and then that all gets recorded straight away onto the Whzan dashboard, and the continence team can see who's actually using the app, how much data they've put in. They can actually change the app for the patient if they decide they want to add another form. And this has kind of really dynamically changed that department. So we're looking for other applications for WhzApp, and we're happy to build all this, and we did build all of this without charge, and it's going out in Sussex without charge, and we're moving it on to starting to notify other areas about this facility in WhzApp. So that covers me with WhzApp, John. Can I see the next slide, please, Amy? Yeah, we're done.
We're done. We're out here, mate.
Yeah. Okay.
Thank you both of you for giving us. Don't drop off though, because there'll be some questions in the chat. I'm sure we can ask at the end. And I'd just like to check in there that I know you have a forum on your website that people can also ask questions in. If Caitlin might want to put the link in there. Equally around learning about quality improvement in your projects, and I know we'll see how Liam's just done this, is we run some quality improvement webinars as well for you to access. So do look at your AHSNs and use them. That's what we're here to do, is to help you put this together and make it work for you. So without further ado, Liam, let's hear the news that you've been doing. Thank you.
Thank you, Amy. Thank you. Well, yeah, thank you everyone for the opportunity to present these slides to you all. I think before I start, I do need to acknowledge that the slides were developed by our clinical lead, Dr. Shani Gray, and also our manager, Louise Key. They were actually developed for the Nursing Time Award. We were a finalist in. We didn't win, but it was quite an achievement to get there. So next slide, please. So the remote monitoring project came out of really 2 key events. It was in response to the COVID pandemic, but also a new agreement for primary care networks, or PCNs. So in North Central London, between January 2020 and February 2021, there were sadly 522 excess deaths in care homes. Understandably, staff and residents were feeling very anxious, isolated, and there were also safety concerns. So out of this, the British Geriatric Society recommended the use of remote monitoring as part of managing COVID-19 in care homes. So there was a very rapid move to remote working to help protect care home residents, which included remote medical video consultations, and things really needed to sort of catch up very quickly, particularly the assessment tools in social care. So it really needed to adapt because it was a big explosion and happened very quickly. But also, secondly, based on the evidence suggesting that care homes residents were not having their healthcare needs met, the new agreement that I referred to before for primary care networks, known as DES, or Directed Enhanced Services, this was developed and aimed to support care homes to improve resident care and outcomes, and increase staff access to support and high quality training that importantly met their individual needs. Next slide, please. So where did it all start? So in November 2020, Louise Keane, who's our manager, she brought together a team of experienced nurse educators, so 5 of us in total, and there was nothing in place, so we got together, we put together the planning, developed a training program for the implementation of this remote monitoring project. So it included a number of tools needed to support and evaluate the learning needs of staff in a variety of different settings. So one good example, the training slides that we developed specifically around using Whzan were based around different resident scenarios. So, for example, a resident with COVID-19, with a chest infection, with a learning disability. So it was very much tailored to the setting that we were going in. And it was also very much a collaborative process. And where we needed sort of specific expertise, for example, for the learning disability homes, we got that through, for example, the GP lead. And we started off by trialling in the initial 4 pilot homes. We trialed the training resources. We gave them a choice of the slides that they wanted. And then based on the feedback and how it went, we changed and modified it accordingly. Then, of course, we had our first big stumbling block. Of course, I don't want to remind you of it all, but in March 2021, we went into complete lockdown, and that completely meant that we had to review. We were going in to do this training face to face, so we now had to adapt the training to deliver it virtually, which was quite difficult because really this sort of training is very much face-to-face training. So there were a number of challenges involved in this, and I will come to those in a later slide. But basically, where we're at the moment, you can see in the slide, which is quite self-explanatory, we're actually up to about 90 homes that we've provided training with Whzan, and that includes supported living homes, as well as those identified on the slide, but also more recently we've moved into a homeless shelter as well. So you can see there's quite a diverse, eclectic range of settings that we're going into. So if we can move to the next slide, where I'm going to look at some of the key principles involved in the implementation process. So one of the key things that we recognise that in order for this project to work, we really needed to embed the learning in the care home environment. And this is the same for any workplace training. You need to follow some principles to embed it, so that's going to increase its chance of success. So one of the things that we found that nurses in the adult social care setting had provided feedback that they wanted fellow nurses to train and support them. Hence the rationale for nurses really leading this project. We've all got backgrounds, we've all got a lot of experience, which helps us to understand the complexities of dealing with this setting, because it is a very complex setting, and also how to overcome the challenges to implementing change, particularly with regards to IT technology, which has their own sort of challenges as well. So some of the key attributes that the team have really needed to show have been persistent. You know, I mean, there've been many times where you felt like giving up, but you really just have to keep going, really being patient, responsive to their needs, changing what we're doing where needed, showing understanding to their situation, because they've been under a lot of stress, as you can imagine. You know, listening to them and adapting to the feedback that they're providing. So that, you know, they're really some of the key characteristics, and they have been really critical in really building and maintaining those long-term relationships that are essential to this project, and also critical to embedding the learning in the homes. Another key principle is collaboration. I mean, like anything, you know, you really need to get everyone on board, buying into the project, and we've done that in a number of ways, and I will come to this in a later slide. But collaboration and involving them in the whole process has been really important, because it's really boosted their confidence and their self-esteem, and that's certainly come out from the feedback. A good example actually of this is in terms of developing the News 2 pathway, which we developed in collaboration with nurses, with the GPs, quality leads, the staff in the care homes, the voluntary sector. So we've had a real broad base of involvement in this, and that's really helped to get their buy-in as well with that approach. So let's go to the next slide, and we can have a look a little bit more about this collaborative approach. So training has not been limited just to remote monitoring. So it's important to stress that really. It's not just about the remote monitoring training. It's about also working with the homes to identify what other training they need. What are their training needs? What support do they need? And really developing programs to support them with them. So we've developed a growing resource of training materials. You can see in the slide the top 5 that have been requested, but you know the points on the slide are quite self-explanatory. But I've got a couple of good examples that I'd like to give that really demonstrate where the nurse educators have made a difference. So, in one home, I supported the GPs who had limited IT skills and were very resistant to engaging with Whzan. They, you know, in fact, it was technology really. They just didn't, enjoy technology at all. They were concerned that they would have to continually access Whzan to check on residents, and that they may receive emails that could potentially be missed, resulting in safety concerns. So, and added to this, there was considerable conflict in the relationships between both parties, and so there were a lot of power structures at play as well here. So there was a lot of meetings, a lot of mediation, a lot of support. That there was a lot of conflict in the relationships. Both of them wanted bypass lines so they could communicate easily with each other. But at the end of the day, we managed to achieve this, reduce the conflict, get the bypass numbers in, and even get the GPs with their logins, which was no mean feat. So that, you know, that was a really good example of really sort of moving things forward and building relationships. And in another home, which was related more to my colleague, they came across a number of safety concerns. The super users were not following the instructions from the training. They weren't escalating concerns. And there were clearly other safety concerns in the home that were picked up by the educator. This led to a CQC inspection, which highlighted that they needed improvements in safety and being well led, and other areas like medication management. So basically, what happened is we put together a coordinated effort from the MDT team, commissioners, nurse educators, to support this home, to improve the safety and to roll out the training. So another really good example about it wasn't just about Whzan, but other needs as well. So if we can go to the next slide, please. Sorry. Yeah, really important as well has been that this project has been resident focused. So we've actively sought to engage residents and gain their feedback where possible. So if we've been training in the home, providing face-to-face training, residents are free to walk in and participate and give us feedback, and they often do, and it's been really quite engaging. Even online they do as well. I know for me, I can give you a very good example of one LD home. I was working with the super users. They were practicing on each other, and then some of the residents came in and they wanted to be a part of it. And so we started practicing on the residents, and they really loved it. They were queuing up to have it done. And then one of them piped up. He said, "No, this is really good, this equipment. I really like this, but there's something missing." He said, "I think it would be better if you added a breathalyzer as well." So there you go. That's your next challenge, to get a breathalyzer in there. So we can go to the next slide, please. So yeah, leadership was a key thing here, and I've previously discussed a very good example of enabling and facilitating care homes to voice their concerns, particularly with, in terms of strained relationships with the GP, and feeling empowered to make that positive change in their working relationships. And as I said, this has needed our support at times and mediation, but we are achieving things there in terms of addressing those power structures that can be at play. The super user model has been a great model for empowering leadership in care homes. So with this model of care, how it works is that the care homes identify their most experienced and respected staff, who receive more detailed training from us and skills and competency sign-off. These super users are then able, with those skills and knowledge, to supervise and train their own staff using Whzan. They can manage the more complex admin and technical tasks, and they provide a good point of contact for us as well. And it's also improved their confidence in terms of communicating with other healthcare professionals. But of course, as the slide says, there were a number of challenging situations throughout the project implementation, and these actually remain ongoing. So the attributes that I've mentioned before have been essential in working through these, but some of the main concerns have been, for example, short notice cancellations. You might turn up and then they cancel on you. There could be delays in starting the training for various reasons. Lack of GP engagement. IT issues for the staff was often a big one. Sometimes their IT skills, you had to spend time getting them up to play with their IT skills. They might not have their emails running properly, or they might have a good NHS email running. Super users leaving and then needing to retrain new staff. This has been something that we found more recently. So you've already provided the training, but then you're needing to go in and do some more training. And also what we found more recently is that homes, although we've done the training, they're not using the kit. So we've had to go back in and see, well, what's going on? Why aren't they using the kits, and support them and give them more education as needing to get them using the kit. So, these have been some of the things that we've found. So next slide, please. So you can see in this slide's quite self-explanatory. It talks for itself really, but the feedback really highlights the clinical effectiveness and value of remote monitoring in terms of reducing hospital admissions, staff knowing how unwell residents are and what actions they should take, boosting their confidence in communicating with healthcare professionals, and residents really loving hearing what their observations are and reassuring them that they're okay, that they're well. So that, that those sorts of things have been really positive. Next slide, please. So the system impact. So Dr. Shani Gray, our clinical lead, she organised for a small-scale evaluation across 10 homes. And this made a comparison of data from January to June 2019 and also 2021. Obviously, it's a small scale evaluation, and larger scales will increase the validity of these findings, but the findings were really encouraging. We found that there were initial cost savings, reductions. There were reductions in London Ambulance Service call-outs, A&E attendances, and also no increases in non-elective admissions. So really positive findings. But like any figures, there's always a story behind them. And what we also found is a reduction in stress levels with staff, because if they're able to identify the early deterioration of their residents, they're able to act on that quickly and keep their residents in their own home rather than going to hospital, which is a great outcome to achieve. Residents essentially are only going to a hospital when they really need to. So that's been a real positive. So next slide, please. So here with this impact study, we made a comparison of 2 homes. Again, self-explanatory, but in terms of A&E costs, there was a saving of around about just a little over £6,000, and for London Ambulance Service call-outs, £1,080, so quite significant. But in terms of, again, the story behind those numbers and data, again, we noticed that there was an improvement in the relationship with the GPs because GPs were not being contacted so much about things that perhaps they didn't need to be contacted about. There was increased staff confidence and also increased healthcare assistant confidence as well. So, you know, really, again, some good positive outcomes there. Next slide, please. So in terms of adaptability, I think the adaptability of Whzan and its additional capabilities has been hugely beneficial and sometimes a really good selling point to care homes. So it's been possible to tailor this to the setting's needs. And at times, as I've said, this has really helped with their engagement. For example, I was involved with one nursing home, and they were really, with this Whzan, you know, we do this already. We don't really need this. So I started to talk about some of the other functions, you know, the multifactorial falls risk assessment, the oral health care record. And then I talked about the potential of the ECG and stethoscope functions. Then they stood up and noticed, and they were really quite engaged about it. And then they agreed to become a part of the program. So I think, you know, this adaptability of what we can offer has been really, really helpful as well. And the other thing as well is the photo, to being able to take photos has been a real good selling point as well, particularly for wound care, because obviously they can take a picture of the wound, and then they can link in with the necessary healthcare professionals, the tissue viability nurse, who can then remotely review that as well, and provide ongoing sort of advice and management of that. So, you know, really good examples of adaptability there. Next slide, please. So in terms of sustainability, obviously sustainability is critical to any project. I've already discussed the super users and engaging homes, but I think other things to mention and other training that we provided are regular touch points to maintain skills. For example, drop-in sessions. We have a weekly drop-in session on Wednesday where any staff can come in. If they've got questions around Whzan, they can ask those, and there's a nurse educator that can be available on there, and another member of our team. So, you know, that's a good opportunity to keep the training going and to support. We have regular newsletters. We've recently started a nursing forum where nurses come to, and we're starting to engage them about other relevant matters as well. Also, you know, the Whzan integration with care home and GP IT systems is developing and ongoing, so that's been a real positive thing as well. And the other thing is we are currently undertaking a pilot with Whzan, integrating Whzan into their pathways, and I've been doing that training over the last couple of days with the two homes that are going to be piloting it, and that actually goes live on Monday. So that's been going really well with the homes as well, and they're really positive and really quite enthused about this as well. Next slide, please. So, okay, so what in terms of what's next, and in terms of continued collaboration across NCL, as you can see in the slide, we will be doing a more formal evaluation. I believe that is going to be by UCL partners now. I've already talked about the 111. We are rolling out an antimicrobial stewardship project as well, which is around UTIs and best practice. So that's with GPs and care homes in terms of, best ways to diagnose and treat. We're developing more student opportunities in care homes as well. So, there's a lot more going on that this is stimulated as well. Next slide, please. So there you can see some pictures which shows a big thank you from everyone who lives and works in adult social care. And I think it's really important to say that they've been through obviously a horrendous time, and they've done exceptionally well in terms of coming on board with this and working with us in terms of moving this project forward. And the final slide just shows all the various collaboration parties that we've been involved in. So hopefully that gives you a good idea about what our team's been involved in, but it's certainly been a very challenging but very rewarding project.
Fantastic. Thank you, Liam. It's been amazing to hear that, and well done on the awards.
Thank you.
Liam,
We'll add some. Sorry, John.
I'll give you a bit of feedback. They also did this, NCL, on their own. As you can see, it's a lanyard which they gave to the care home staff, and it's got the vital signs on it, an S-bar. So it was a really useful, tangible thing to give to people working in care homes, which came from you guys. And so not just that, I think it goes beyond that. And this has been, I've been sending copies of this all over the place, Liam. I hope that you don't mind. But people.
No, not at all. Yeah.
But can I just also echo what Tara said? That was a fantastic presentation. Thank you very much for taking the trouble this afternoon.
No, my pleasure. Thank you.
Thank you.
Thank you.
And Liam, do share the link for those lanyards if you want to put them into the chat. I'm sure people will value having those available to them, and we can circulate that for you at the end, because we'll try and put this up on the website, the recording, and also the links to our quality improvement training as well, so people can start to do this in their own projects, if that would be applicable for everybody. There is a couple of questions that's come up. One of them is around integration, but I know we've talked a lot about integration. The other one is around consent. And there is just one thing I want to pick up on for care homes and their data protection toolkit. This is an annual renewal. So do take that back and remind care homes that they do need to do that. Otherwise, they'll lose their secure email, which then if they do want to send things via the PDF file, they're going to struggle to do that without using NHS Mail. The other bonus for NHS Mail is that they can access a lot of external training as well, like the care certificate under Skills for Care, which they can't do without that free of charge. So I'm here to try and save the money, as we all are trying to save money, and empower our staff across the system. So I suppose my question around consent, who would like to have an answer for that? Maybe John, you've done a lot of work around consent, haven't you?
Yeah, sure. And it follows, well, the process must be there's the DSPT part of it, the protection toolkit, and then there's also the relationship between the individual and its care home. So the individual has good permission to the care home for them to share data. If they can't do it, then close family member must do it. And then the care home must in writing, grant permission to the GP practice with the appropriate GP in it who will look after his or her patients, their client in that care home. And once they do that, and the way we work with NCL is, the simplest way to do it is once and Liam does loads of these, Liam sends me a note saying, here's the permission from the care home for Dr. Liam to have access to see these cases with these people. And we then arrange for the login, so the GP then receives their username and login, they set it that way. And if there is a care home, and if this is not uncommon either, where there may well be residents who are spread across 3 or 4 GP practices, there's a way that we can parcel up, if you like, or put the appropriate resident into a caseload for that specific GP practice. And again, they have to go through the correct IG process to make sure that written permission is granted, and then we click the button and off it goes. And I also copy then in the IG lead at NCL to make sure that he knows that we've done it as well.
Thank you. Keith, do you want to add in any?
Yeah, I would just like to say in WhzApp, when a user logs in or creates an account, which they can just do from a poster or a barcode, there's a consent form that pops up, and in order to be able to go further, that end user has to give their consent at that stage.
Fantastic, thank you. I suppose one of the things we haven't talked about is the multidisciplinary ward round, and how products like this can help to organise that ward round for GPs, and perhaps think about how they can better spend their time or any free time, so they can order their visits and equally start to prioritise who they need to see first, which will free up other clinic times for other clinics that they've got to do. Do any of you use that as part of your multidisciplinary ward round? Sorry, I can hear Keith. That's it.
Well, can I also add something on that? I mean, in that the conversation yesterday with LCW about creating a frailty ward, you know, to bring in consultants or secondary care into that is ongoing. I don't know if we can talk about it yet in detail, but some people with very complex conditions are likely to sort of come into this too, that being with multiple sclerosis and Parkinson's. It's a project we've already started working on that, which again will be an MDT approach to that one, because in their case, these people require special needs, certainly those in care homes. So it's ongoing. I think, you know, which has surprised us, where we saw this going, is that in a couple of weeks' time, we'll be having a conversation with people in Chesterfield about an angina clinic. You know, how we can set them up using WhzApp for an angina clinic. And again, as Keith would say, you know, they have to go through the consent process to do so. But, you know, I think what we say is, you know, if there's something which you're clearly finding complicated to record and share that data, talk to us about it. And then we can go from there.
Thank you. And I think some of this fits into what some people will be familiar with is the virtual wards and the COVID oximetry at home work that went on during COVID. And this is an extension of that now as we start looking at more complex patients that we can monitor at home or in their community, or bring equally a group of responders together who manage several patients in more than one area. So that's how we can start to work it on both ways. So we can start to use equipment now as pooled equipment that people can take home with them from hospital and equally be delivered to them and then come back into the pool as a resource. There's one other question around the GP deciding what data is migrated across. And I know you've answered that in the chat, John. I just wondered if you wanted to add anything around how that data is validated, so the GP knows who's taken those observations and not taken those observations.
Yeah, sure. So what can happen, or does happen, because we've tested it, is that the GP will open his or her EMIS, and then they can click on Whzan, and that will pop the Whzan data that's been collected, showing the observations, blood pressure, pulse, news to, etc. And it's got next to it, it's got a note saying this information is being collected within a care home. And so therefore, and then the GP reviews that data, clicks on upload to system, on upload to EMIS, and it goes into the patient record system. So, you know, some people know, you know, me personally, I would like my observations to be checked by a clinician before we go into my patient record. And, you know, so you have to look at what the Whzan box is all about, and the environment which it's used. You know, you don't use Whzan before you reach for the scalpel to start operating on somebody, but you can use it as the alarm bell, and then that data can then go appropriately reviewed and then into the patient. But it doesn't mean the GP has to then type in anything. It's simply review the data, click on the upload button, and it goes straight to the patient record.
Fantastic. Thank you. I did want to cover the validation process because I think it's really important that, you know, we have that clinical insight to all of this and actually move that responsibility from what people perceive that staff should be having to have, and it's not. It's about clinicians reviewing that data and making sure that it enhances their clinical decision making, not does it for them. And with that, I know we've got a couple of minutes to go and people are starting to leave. But just to say, we'll put extra links in the chat. We'll send out the link to this recording for you. Do become part of this community and keep feeding back to us, because feedback is so important that for the sustainability of all of these products, is that if we can't get feedback and we can't translate that into how you want to use it, then it becomes something that sits on a shelf, and that is not what it's there for. It's here to support patients and the people that we look after. So that leaves me to say thank you very much to Liam, especially for sharing his great story, and Keith and John for joining us, and Amy and Caitlin to support this as we've done this webinar. Thank you very much for attending.
Thank you. Happy Christmas.
And that.
Yes. Thanks, everyone.
Thank you very much. Wonderful.
Great job, Liam.
Thank you everyone.
Liam, wonderful. Really, really wonderful stuff.
Thank you.
Thanks, Liam.
I'll say goodbye.
Okay, have a good
Bye.
afternoon. We'll see you soon.
See you soon. Yeah.
Okay, mate. He was great, wasn't he?
He was great, yeah.
So,
Amy, do you want to stop recording, if possible?